This is A Change Physician, episode 216. Welcome back to The Change Physician. I am Melissa Katie, the Challenge Doctor, with my co-host, Dr. Kevin Cuccaro. And we're going to do a little chat today that's not typical. I don't think we've really talked about it in just strictly about death before, but I think it came to mind recently because of actually a close friend of my husband's brother had passed, and there's all these nuances of discussing death, or how do we deal with death when maybe medical decisions are going to need to be made, or what do you say to children, or how do you deal with the funeral, and do you want to see a person that's not alive in a casket? All these things just made me think about how kind of this avoidance we have. And it's interesting because we've done this discussion about pain avoidance, or, a totally different topic, but there is something uncomfortable to a lot of people when we talk about death, and but it is part of life. And I don't think we all want to talk about it all the time, but I think there has to be some element of acceptance that this is part of the life experience, is that we all will die one day, unless that changes. I mean, this is the context of what we're dealing with here. And even affects even our decisions, our planning. A lot of people don't want to do a will. They don't want, I mean, there's so many elements tied to death that I think a lot of humans avoid talking about it, dealing with it, accepting it, and realizing that we are mortal. So I think that if it's okay with you, Kevin, I'll just mention, a couple of things in my training that I think are relevant, unless you have a comment you want to make now.
No, go ahead.
Okay. So I guess I've been in a couple situations that I was just kind of thrown into it as a resident. I was actually an intern in surgery, and I had to trying to decide to withdraw care, have those discussions. Like, I didn't have anyone around me to do it. Everyone was busy, including my faculty and all that. So I'd have to have these discussions after rounds were made that there was going to be a discussion of withdrawing care. And then it's like, do you do it with the breathing tube still in? Do you take the breathing tube out? And there's these really stressful moments that I had to deal with as a resident. But it's not just like, how are we going to physically do these things? But then you have, oh, by the way, the family, an extended family of 20 people in a room, I'm having to discuss the plan and tend to their emotions, and tend to letting them know what they might see or witness, to prepare their brain for it, and to help them be the best, support they can for this person that is probably going to expire pretty soon, or it could be prolonged, which is very uncomfortable.
Well, they're going to expire. The question, when it is
right.
Kind of the question there.
And the other dilemma is the double effect of providing comfort care of maybe some morphine or some other types of medications through an IV to when they're struggling to breathe. How much is too much? But there's all these questions and ethics that you start learning as a physician, and it can be very uncomfortable to try to make those decisions. And then when other people don't agree with the amount you gave, but yet there's suffering right in front of you, and what you're seeing, you're trying to treat that, but yet the opioid is making them not breathe as well, and they expire a little faster, but that's the double effect. So anyway, that was just one of my, thinking about my residency or internship experience of the uncomfortable situation there. And that squeezing, and this is something that you'll hear in a future episode, is trying to squeeze every ounce of life without any quality to it, and doing a ton of procedures to prolong life that doesn't necessarily get them out of the hospital or give them any quality, doesn't always make sense in medicine and life. And so I'm wondering what your thoughts are on, of course, there's a lot, you can go in a lot of directions with what I said, but any thoughts on it?
Well, yeah, I think what we're really talking about is the spectrum, right? So there's a spectrum when it comes to dying. Mm-hmm. And you're talking a little bit about the kind of that close end spectrum when we know someone is we know someone is in that process. They're usually in the ICU or whatever, and it's total palliation. They're not going to recover. What are we going to do now? Are we either going to try to extend these biological functions for the best possible, or not the best, for the longest possible time, because we can do that pretty well? Or are we going to let the natural biological process simply end, right? And then we can do that in such a way that is somewhat more compassionate, and a lot of times is more compassionate for the people in the room. So we're giving opioids not because we're necessarily sparing somebody who's got brain death, but we're trying to slow down respiration so they're not gasping and doing agonal breathing in the room, which makes it much more distressful to everybody else that's involved.
Absolutely.
But I think, that comes up quite a bit, but I would love to push it out. And I think in America specifically, we don't think about, we're kind of aware at this end, and everybody's like, oh, do everything you possibly can unless there's nothing you can do. Right. Okay. Well, that's kind of useless. And so we're thinking just to this tail end here, rather than pushing out, hey, let's talk about dying on the spectrum of living. And that is a very difficult but useful conversation to start having with your friends and family, to kind of figure out, well, what is it? The difference between a health span and a lifespan, living healthily, being able to do the things that you want to do, to be able to be fully functional. That's a health span. Lifespan is when the biological processes are going on.
Right.
And in a lot of people cling to this idea of lifespan and don't necessarily think about, health span and what you as an individual or want, and making sure that your family members are involved in that discussion as well, so that they know what you want when you're perhaps be incapacitated, because that infects the continuum of care. My ICU experience that I come back to all the time was a guy who was 90 something years old, who had an aortic valve replaced. And this was pre-TVAR. So now they're doing ones where they actually can go, interventional cardiology are doing. They're not nearly as inventive. You're not putting people on circ arrest anymore, unless, circ arrest, cardiac surgeries, when they split the chest to do these valve repairs, they have to actually stop your blood flow. It's extraordinarily traumatic on the brain and body.
Yeah.
And this guy was 90 something years old, was a farmer. And I think he became symptomatic, and they went in and he found he had critical aortic stenosis. And so the decision, well, what are we going to do here? Well, if you have aortic stenosis and it's symptomatic, generally, and I haven't looked at this data for a long period of time, generally symptomatic aortic stenosis, mortality is about 2 years. Like, you're going to die within 2 years is kind of the thing. But you also have to look at who the individual is. If you're 90 something years old, I don't know what his other health problems were or whatever, you're going to do this major operation that he may or may not ever waken up from. So now we're shortening this whole time period. Long story short, he had the replacement done. He was in the unit, in the cardiac unit. I was on the unit at the time. And then basically everything else started to fail. So he ended up having, something went wrong with his liver. I mean, we're taking him down to get like all this crazy stuff. He never got taken off the ventilator. He was always intubated the whole time. He was sedated the whole time, and had to have the discussion with the family to withdraw care. And we actually did. We had the whole family in there, and we did it very slowly, and we kind of weaned it off. And it was a what I think was an overall positive experience, as much as positive experience you can have in this fake sort of environment. But all I could remember thinking is, well, what if he never had the surgery done? And that has and that means you have to think about your own mortality. How is it that I want to die? How is it do I want to spend my last moments? And the older that we get, the more important those decisions are. If I was 95+%, 90, however old, and then I knew, well, you're probably going to die in 2 years from this, or we can do this surgery, and there's a risk associated with it. You could probably die. You may have a stroke. You may never walk again. You may be in a nursing home for the rest of your life because of the punch that we're going to do to your brain when we put you through the surgery. That to me was, that's threatening my health span. Maybe what I can do is spend the remainder of these 2 years really enjoying my life. But I also think about death a lot, and my family has a tendency to think about death, but we don't ever have these discussions in the United States. When we talk about in a future episode here with Dr. Ian Harris, and I can't remember the full quote, so I pulled up another one. But this one was basically, only in America do people think dying is optional, because we don't talk about this stuff. I cannot tell you how many people I know who don't think about how they want to die. Instead, they're always pursuing what possibly could be done to extend a life, but not necessarily think about what kind of life do you want to live. And so that to me is a much, they're all important discussions to have when it comes to death and doctoring. But from a physician standpoint, we know a lot of the times that we do is futile care, and yet we don't talk about it frankly with patients. And that to me is a total disaster. Even when people go in, I can't believe they're doing all this stuff to this person. Well, did you tell them that this is futile care? Did you introduce this discussion at any point? I don't want that ever done to me. And it's even worse when the family members do it. When you hear them outside the room, oh, I would never want this done to me. But you're doing it to your family member. Why are you doing this to them?
So they don't feel guilty about not trying everything.
Intervening. Yeah.
Or you see this happen, estranged children, or they never did anything, and the psychological impact on people that never had the conversations, didn't have the healthy conversations, and now they're just thrown into this, and they choose, well, you got to do everything. Or, believe me, there's somebody that gets checks because they're alive. I mean, the financial benefit or of them going or staying. No one, I mean, that just sounds horrible to talk about, but there are some interesting psychological implications and decision-making when a family that has not had good, healthy conversations around this, or things haven't been ironed out or whatever it is, just to decide the right thing to do for the patient, not necessarily for the guilt of someone that never was there for that person. Or, so there's a lot that, physicians have to contend with surrounding whether or not to withdraw care or to continue to do all these things. Yeah.
Yeah. And it's, yeah, but I mean, even on the physician standpoint, and I think this is like when it comes to like death and doctoring, like the things I think about is not a lot of people understand the impact of medical procedures that are being done,
Yeah.
or what those are alongstream or downstream from them.
Yeah.
And so one of them, I'll never forget when I was doing cardiology as an intern, and I was working with a electrophysiologist and doing EB studies and stuff, and she was talking about AICDs, automatic implanted defibrillator devices, which are basically they put them in, and then when your heart goes into a fatal arrhythmia, it shocks it out. And I remember her distinctly saying, "I would never have one of those put in." And it was like, "Why? All these people running around." She goes, "Because now you've changed the death from the quick death of cardiac causes to the slow death of drowning by heart failure." And I've always thought about that. Now, would it make sense to have an AICD in certain situations? Yeah, if you're a younger person that maybe have some weird cardiomyopathy,
yeah,
and you can eke out 20, 30, 40 years of it just because you may have a risk of a fatal arrhythmia, that's one thing. If you're 65, 75, 85, obese, diabetic, multi-organ disease,
yeah,
COPD, and then number of it's like ischemic cardiomyopathy, so you have a heart that's not functioning well at all. Do you really want now this defibrillator that will take away the quick death and give you the long slown out death of heart failure, where you're basically slowly drowning in your own bodily fluids? And we don't talk about that, but people will happily pump those things in every day of the week.
Ooh, that's some money.
It is. There's money, and maybe they're not thinking about that conscientiously.
Sure.
But because we've talked about, there's a lot of incentives that we do that we aren't conscious of, and financial incentives is definitely one of them. But there's a lot of care that gets done that I don't think physicians we wouldn't want for ourselves, and yet we do it to our patients.
Mm-hmm.
We're not having those discussions. We're not being honest with our patients about those. And maybe we assume that they don't want to hear. But that's always a really difficult place to be in when we're assuming someone doesn't want information that we never told them because we don't actually know what's true, right?
Yeah.
We're just, and yeah, I don't know what the answer is on that, other than the fact that assumptions are based on nothing. They're just like what we believe may happen.
Right.
And then and until we've actually tested it, we don't have any data to make a good decision with.
Yeah. Well, I do feel like you can preface when there's uncomfortable conversations or something you feel like they would not be quick to receive or want to receive initially. Like even when it comes to like pain, stress, anxiety, death, like all these things that seem uncomfortable, like I find that and it's just maybe my perception, but I find that sometimes if I just either ask permission to discuss something I think that's important, get their okay, and or just say, I know this may not be comfortable to hear, but I feel obligated to just express to you or explain a couple of things that might help you make decisions or just help you get a little different perspective than what most patients have. Excuse me. But I find that it just helps buffer that discomfort that maybe you are assuming they have. But there's times where I know that it has been helpful or they're just being, polite, but I get, a thank you. You don't know which person really needs to hear that. So who else is going to talk about it? If we're not comfortable.
Well, and that's a great way to do it, is to ask permission, right? Because by asking permission, you're at least providing them
Control.
a sense of control.
Yeah.
And or recognizing that there's more information that they need to know, but whether or not they're ready to hear it right now. And that's the other thing. Because the other part about this and makes it so difficult is we like to think that these decisions, which are extraordinarily difficult, are always in the perfect environment.
Yeah.
And that almost never happens. These decisions are taking place in the worst possible scenarios when those decisions are most difficult to be made. When someone's going into the emergency room with chest pain, when person's going in because they had whatever trauma. These are traumatic, intense, chaotic times, and we're trying to make extraordinarily difficult decisions in those moments. You may not be able to do it right then, but there's a lot of downstream effects that if there had been discussion beforehand, maybe they won. I think about people who went in with like a fatal arrhythmia, whose life was extended despite the fact that they said they were, I think they were even DNR, DNI, but because they're in, they get thrown in there and then maybe someone doesn't see it. And then all this catastrophic downstream stuff occurred that kind of limped them along for a couple more days, maybe, I don't know, maybe a week, but probably should not have been done to begin with. If people started said, well, let's think about what we're doing here a little bit more in the person that we're involved with. And, or again, your family needs to know this stuff, because to ask them to make a decision such as this without having full knowledge of what it is that you actually want, there's a good chance, even if they know what you want, they're still not going to be able to make that decision, because it's absolute chaotic, total hectic. And all of a sudden say, well, I don't want anything being done when you're in the middle of an emergency room and someone is in like having a fatal arrhythmia. I can't even imagine what that would be like. Say, no, don't do anything. My parents said, don't do anything. That's hard. That's really hard to do. And the best prepared person is going to have difficulty doing that, even though that may be what the person wants.
Right. No, I totally agree. There's one last thing I wanted to mention on this topic, is that when you do confront or discuss something that's uncomfortable, I think physicians in particular need to really think about how they are speaking, the positioning of your body, a lot of the non-verbal cues and gestures that you make, and in essence, show compassion. Personalities are different, but sit down, don't be speaking down to them, in a very calm, professional voice. And at times in the right circumstance, which depends on the relationship you've developed with this. If it's a chronic situation, these people, sitting down, maybe leaning forward towards them, showing care, whether it includes putting your hand on their shoulder or on their hand, like whatever makes sense. Obviously that can be tricky depending on culture and other things and generations. But I found that to be one of the most powerful ways to connect and be heard in a way that doesn't seem threatening, but genuinely makes them feel like you care. And so I don't think we get enough training on that. And I've heard too many horrible stories of how people were talked to and the way that they were treated. And that's completely uncalled for. I understand that we could be stressed and a lack of sleep and all of that. But at that moment, you have to be them and understand what you are basically telling them and how they're going to respond, at least to the best of your abilities. But there has to be a connection. You have to kind of in that moment, take a deep breath and just be there with that human being that's going to have to make a very difficult decision, most likely. So those are my last things I wanted to mention.
No, I think those are great actionable points that we oftentimes take for granted that people know or assume that they know. But people don't. Like being able to do empathetic communication is a skill. And you can look at it in ways of, well, how can I make this less the least threatening possibility? So like I love, I used to kneel. I like squat down. That was the way I would do it. And eye contact. And that's uncomfortable. People like, oh, that's uncomfortable to me. Well, it is uncomfortable to me, but you're trying to connect. And the other part, if it's uncomfortable for you and they see it's uncomfortable for you, we get that kind of reciprocal
discomfort,
empathy as well, right? And they're like, recognize that this is hard for you as for them. There's a shared connection there. So if you perhaps weren't involved with any of that stuff, those are really simple things to do. Eye contact and get yourself below them.
Yeah, absolutely.
From where you're looking at, and then soft voice, making sure that your voice is soft.
Yeah,
simple little things like that, but
absolutely. Well,
not
like
fun
that
stuff and not the joy, but man, so important, because how often we just, death comes for us all, and how you want to die, I would say is it's an important question for everybody to start thinking about. And that can change. I mean, as you get older, things, if you were young and you're like, oh, I want everything done to me, blah, blah, blah. Well, you can change that as you get older, or maybe vice versa. Maybe you're like, oh, I don't want anything done. And then you get older and it's like, I want everything done, or I want this, or for whatever reason. Express it though, and have some good reasons for it. And I don't know. And there's so many, sometimes we should talk about the fear of death, because there's a lot of fear of death going on, and but it's doesn't be there. So you can either like face it and like discuss it and kind of map it out, or you can run away from it and it's still going to catch you. It's just it's going to be a little bit scarier because you haven't taken the time to actually define or look at it or see what it is that you're scared of when it comes to death and dying.
Yeah. Well, before you take us out, I just want to remind people that it is helpful if you don't have a will and you own things, or you have children, or you have people that you love. It's best to just get it done, take care of it. And medical power of attorney, all these things that can help your loved ones make better decisions for you based on what you really want. I'm not proposing any particular attorney or someone to help you, but get that taken care of, schedule an appointment, just get it done, and have a safe place for it, and make sure somebody knows where it's located, or a couple people. And that way it makes everyone's life a little bit easier when potentially you might be at that point of death. And not something everyone wants to talk about, but it's all you, Kevin. Take us out.
Talk. Tell everybody what it is that you want. And if you tell everybody, all your family members, all your friends, then you're more likely to get what you want. Not guaranteed, because that definitely happens in the chaos of things, but you're certainly going to help people feel better about making those decisions if they believe that those are the decisions that you want, rather than trying to work out what it is that they think that you want. That's a very challenging place to be in, and a lot of guilt associated with that. What if I did this, or what if I made the wrong decision? What if I had tried to do that? What if, and we'll what if ourselves into oblivion. So All right. Well, thank you, Melissa, for introducing this topic. It's a very important one on death and doctoring. If you've had your own personal experiences and or challenging ones, or maybe ways that you've dealt with it, maybe you're in palliative care or oncology and you have some hints in things, let us know. You can email me directly at drkevin@thechangedphysician.com. And until next time, stay well.
Take care.